Hello, everybody, and thank you for joining us this evening for our presentation of tongue ties in growing kids and grown adults. There's more to it than meets the eye. And there's a very specific reason why I chose that title, because there is more to it than meets the eye. So we'll get to that part in just a moment, but let me take a moment to introduce myself. My name is Becca Rose, and I am the founder and the primary myofunctional therapist here at Wisconsin Myo. I hold multiple high-level certifications in the field of orofacial myofunctional therapy. But I do want you to know that the opinions that I'm presenting tonight are my opinions. They are not necessarily the opinions of any of my educating platforms. Their opinions and ways of doing things in my practice that I've adapted over the years based on what I see in my clients. So just a little FYI on that. And also, I just want to mention, so we have to say the disclaimers and all that good stuff. So presentation tonight is for educational and informational purposes only. It is not intended to be a substitute for professional or medical advice, diagnosis, or treatment. Always seek the advice of your physician if necessary. Our practice does not work with or address infant tongue ties or other oral tethered tissues. So if you have specific questions about babies and infants, I would encourage you to directly contact our office, and we can help to connect you with providers that deal with that specific population of people. So with that said, let's jump into it. All right, so there's more to it than meets the eye. Okay, there's a lot of talk about tongue ties. Tongue ties are not new. This has been around for a really long time, but what is a little bit new is the different types of tongue ties that exist that many people are not aware of. So we're going to talk first about the anterior tie, or the traditional tie that most like doctors or dentists or ENTs, pediatricians, pediatric dentists, this is the presentation that they're mostly looking for, is this tight little band of tissue that's connected to the very tip of the tongue right here and kind of connects down into the floor of the mouth. So this is considered an anterior tie. And oftentimes in the traditional medical and dental environments, they're really only looking at this tip of the tongue, this part right here, okay? And then that tie that goes down into the floor of the mouth. That's the only thing they're trained to really see, okay? So if you don't, and there's also like that appearance. So this is why I chose the title of More to It Than Meets the Eye, because oftentimes in that traditional setting with those traditionally trained providers, they're really just looking, with their eyes to see, what does this tie look like? And they may be looking at other things like a shape. So this person has really like this heart shaped, you can see me kind of drawing on my screen here. They have this heart shaped tongue. We can see some of that heart shape kind of go underneath, and then the tie, the pressure of this tie is kind of pulling that tongue into that shape. So hopefully you can kind of see that with those markings too that I'm making on my screen. But they're almost always just looking at what it looks like. What does the shape look like? Does it have any kind of knot or dent in the tip of the tongue? And oftentimes they'll ask questions like, can you lick an ice cream cone? Do you have any speech problems? And if the answers to those questions are, no, I can lick an ice cream cone and I don't have any speech problems, then they typically look at you and say, nope, you don't have a tongue tie, goodbye. But that's really where the standard of training in tongue tie and tethered oral tissues really stops. So if they're not seeing that tie right on the tip of the tongue, they're often told, no, it doesn't exist. That's not a real thing. And then they really don't have the knowledge or the education of how the tongue actually functions. Okay, so that's kind of what's going on with an anterior tongue tie. This slide here is showing specific examples of a true anterior tie. So these are the very specific types of attachments and string. We call this a frenulum. This is really what doctors are looking for, or dentists. And if they don't see these ties right on the tip of the tongue, it's easy to be missed. And it's easy for them to kind of dismiss you and tell you, no, there's no tongue tie. If you do have these presentations, though, they're usually like, yeah, okay, I see what you're getting at. I think I agree with you. And then there's options that can happen from there, okay? So, oh, where's my video? Oh, here it is. Okay. I'm not sure if the video is going to play. I might have to start it from up here. All right, and close down a little bit. Okay, so that is literally one of my clients. He was a recent client. He's 7 years old, and he does have that true anterior tie. So during like an assessment, during a myofunctional therapy assessment, we'll often use these range of motion rulers and take different measurements of you opening your mouth, lifting your tongue, how far can you lift your tongue up, things like that. And if we look at this video again, you can really see that he literally, and you can see that little string like right there. It's hard to see, but you can see the string. And close down a little bit. And you can see how it's right there attached to the tip of the tongue. And so I knew that this child was not going to be able to lift his tongue up so that I can take a measurement. But I still take photo and video of these things so that I can look back later and compare them to new photos and videos that we take throughout the myofunctional therapy process and the tongue tie release process. So this child was actually referred to our office by a pediatric dentist who does have some knowledge and awareness in tongue ties. So that was really refreshing that the dental office, like, yeah, okay, this child has that true anterior presentation and he's very restricted, so we need to get him some help. So they referred to our office so that we can get his tongue prepared for a tongue tie release. And then we also have to do some preparation after the tongue tie release as well, so that we can minimize scarring and just ensure that there's proper healing of the tissue taking place. Okay, so this photo here is another example. I don't know why my my little cursor is going crazy, but anyway, this is a picture of an anterior tie. But I put this one in here anyway because tonight we're going to talk mostly about the hidden ties, or what we call a posterior tongue tie or a mid-tongue restriction. You might hear both of those terms being used within the airway space, the myofunctional therapy space. So the tongue tie is not just about what it looks like, okay? The posterior part, or the hidden part, it's an extension of this tissue. So we can very clearly see this lingual frenulum, or this anterior tongue tie, but the posterior part of this extends a little bit further underneath this muscle here, underneath this muscle here, and this is connective tissue, okay? It's also considered fascia. It's folds of fascial tissue, and not everyone really knows what fascia is, so we'll talk about that a little bit too. But if somebody has an anterior tie, so those ones right in the front that we've just been talking about, if they have that anterior tie, there's always a posterior component to it that we can't see with the eye. So then the question is, how do we know that there's a posterior tie? And I'm so glad you asked, because that's what we're going to talk about tonight. Okay, so the hidden tie, the posterior tie, the mid-tongue restriction is not about what it looks like. That posterior part extends deeper into the tissue, into the muscles. And why it matters is that when that restriction is present and it's affecting function, it limits the vertical lift of the tongue. So it limits how the tongue can elevate and engage with the roof of the mouth. It also affects, so here's my hand, it also affects the mid and posterior part of the tongue from being able to lift and engage the way it's supposed to. And when that tongue doesn't have its full range of motion, it creates a direct link to these chronic compensations. And we're going to talk about compensations too, because the way that this tongue moves or the way that it doesn't move has an effect on the whole rest of the body. All right, so I mentioned that the tongue tie, and it's more specifically the posterior part, that deeper part of the tie, is part of the fascial chain, okay? So this is the deep line fascia, this image over here, this is the deep line fascia. And what fascia is it's a continuous chain of connective tissue, essentially. And this chain, it starts underneath your tongue. So this is your tongue up here. And this fascial line, it literally goes all the way through your body, through your diaphragm, your lungs, pelvic floor, legs, all the way down to your toes down here. So this is literally one continuous sheet of fascia. And so not everyone really knows what that term fascia is. So the easiest way to really visualize it is if you think about a raw chicken breast. And when you see that really thin, like white layer of tissue, that's fascia. And in our body, the fascia is this very intricate, it looks like webs, like almost like cobwebs, but it literally surrounds and encapsulates every like fiber, muscular fiber in our body. And it also, it surrounds all of our organs. So the way I like to describe this, if someone is coming for an evaluation, they're like, oh, I think I have a tongue tie, and we do their functional assessment, and then we start talking about this fascia. Sorry, there's this little tiny like fly that's like just buzzing around my head here. We start talking about this fascia. I like to describe this as like a chain link, okay? So this is a link of chain, and you have this first link up here that's all kind of twisted and kinked and, tight and restricted. Over time, it starts to have an impact on the rest of the body. It starts with forward head posture, and then that affects our shoulders. Our chin kind of gets pulled backwards, and it just has this negative cascade down through the whole body. So literally, when we're talking about a posterior tongue tie, through the fascial system, your tongue, your mouth is connected to your toes, to your feet. And that's a pretty profound, if you can imagine that. But this is why, and this is how. All right, so if you look at this lady, this picture of her tongue, wow, okay, she does not have that tight tongue string, right? That frenum. I'm going to go back to the previous one. So this picture and this picture look a lot different, right? But there's a lot going on with this tongue here as well. So she does not have that anterior tie like we saw on the tip of the tongue, but she does have that posterior restriction, so that posterior tie. And when I'm looking at this, I see a lot of difficulty. This tongue, even though it looks like that person can lift their tongue up really tall, this is not easy for her to do. And you can't see it in the picture here, but in real life, even though she has a turtleneck on, I could see her tensing her neck muscles. She was kind of straining her eyes, like looking up towards the sky, kind of in distress, like, oh my gosh, what's going on here? So I'm drawing my little eyes here. So we're looking at compensations, and we'll talk about that a little bit more too. But I do want to point out this phrase right here, because when we say posterior tongue tie, a lot of people think, oh my gosh, they have to cut the back of my tongue. No, a posterior tie is not in the back of the mouth. It's not the back of your tongue. It's not near your tonsils. The posterior portion, like I mentioned before, is you have your string, and then right behind that string is that fascia. And so that's the posterior part, okay? And the other reason why that's considered or called a posterior tongue tie is because that fascia embedding into those muscles underneath the tongue directly impact the ability of the posterior part of the tongue from being able to lift up and down in the back the way it should. And if that doesn't happen efficiently, then that's when we see problems with our symptoms like snoring and grinding teeth. And we'll get into that a little bit more as well. All right. So, what kind of impact does a tongue tie have on children that are growing? There's lots and lots of impacts. So, the first thing we have to understand is that the tongue is the architect of the mouth, of the roof of the mouth. So, in the ideal situation, the whole tongue body should be able to live and rest nice and comfortably up within the upper jaw. I've got my teeth here too. So the tongue should be able to stay all the way up here inside that upper jaw. The upward and outward pressure of that tongue. So if we've got the upward pressure taking up the space inside the mouth, and then the tongue, it creates this outward pressure as well. That helps to actually grow the face. That pressure helps to grow the direction of that upper jaw. And the reason that that's important is because in order for us to have a nice patent and open airway, we should have nice wide upper and lower jaws. If the tongue is in a down position all the time, there's no pressure here. So this pressure of the tongue is absent. And then that means we have counter pressure from our cheeks that kind of squishes against that upper jaw. And over time, the teeth, especially when we're kids and we're starting to lose teeth, the teeth start coming in and they're very crowded. You can see in this picture here how crowded all these teeth are. This upper arch is very narrow because it wasn't formed by the muscular pressures of the tongue. And then when we have a very narrow and high vaulted upper palate, we tend to have a lower jaw that's kind of set back a little bit further. And that is that like profile we see where sometimes a child or a teenager or even an adult is described as just having a very set back jaw or having really no jawline at all. A lot of times that's because of how the jaws have developed. The lower jaw is going to follow the growth pattern of that upper jaw. So if we have that tongue up there, then we're going to get good facial development. And then our lower jaw is going to be able to grow forward and we'll have more open airway space. And then we'll have, it's not about aesthetics, but we'll have a more aesthetic facial profile as well when our facial structure grows wide instead of long and narrow. So yeah, if the tongue is tied enough that the tongue just like literally cannot fit comfortably into that space up top, then that's when the arch gets high and narrow, the teeth get crowded. And then this downward position of the jaw really makes it difficult to keep the mouth closed. The body has to work a lot harder. So if our jaw is kind of set back further like this, it takes a lot more pressure and intentionality to be able to keep the lips closed. So then we become mouth breathers. And as we become mouth breathers, our nasal passages get inflamed and our nose stops working the way it should. And then we possibly get adenoid and tonsil enlargement. And then that blocks the airway space even more. So that's encouraging that long facial pattern, which I mentioned earlier, versus that nice wide structure that we want to see. Okay, so let's talk about adults for a moment. So we start out as those kids who were mouth breathing. We get enlarged adenoids or tonsils. Some kids have those out, some do not. Our nose is really congested all the time. We can't breathe through our nose. So if the nose isn't doing its job, then our mouth has to open. And it's hard. The nose is considered like some people call it a use it or lose it organ. It needs to do its job. And so if we become those kids that are chronically mouth breathing, we're congested all the time, then we turn into adults that have more and more symptoms and compensation. So one of the biggest compensations that we see or maladaptive habits that we see for like a small airway and low tongue posture is chronic neck tension, shoulder pain, even tension headaches, or posture compensations. So if you imagine, like we talked about already, your chin kind of comes back in order to open our airway, because now we're closing off our airway space here, okay? So in order to open our airway, we have to start kind of pushing our head forward. That opens up our airway tube so we can get better airflow. We also see in adults jaw pain, clenching and grinding, TMJ, because the muscles that support the jaw have to overwork to be able to stabilize now this head and neck posture that is atypical and isn't cohesive to good growth and development and airway function. And then we see that kind of transition into airway and sleep concerns. So a setback jaw and a low tongue, it makes it more likely for the tongue to actually fall back into the throat where we're sleeping, and it can have a contribution to sleep disordered breathing and sleep apnea. And it's not just about the tongue now, because now remember, we went from childhood with long faces, high vaulted palates, crowded teeth, maybe we needed braces, and we maybe dealt with some of that when we were a child, but now we're adults and our neck hurts and our shoulder hurts, and there's lots of reasons why that could be. So it's not just a tongue issue, but the tongue is a huge component in that overall posture. But now we're adults who, okay, I never used to snore. Why am I snoring now? Or we're in our 20s or 30s and we're of healthy body weight and a healthy lifestyle, and we're suspecting we have sleep apnea. And I was diagnosed with that when I was 28 years old. That was pretty young, and I wore a CPAP machine for 14 years. If any of you know me or have talked to me, you've heard me tell that story before. So it's not just about where is your tongue in your mouth, but now as we have this forward head posture, we kink off our airway. Now we have less air to go. We have less volume for air to go through our airway. And then we have to start breathing deeper and heavier through our mouth. And then this translates into deeper breathing at night. And now we have to take more air volume into our body at night to like keep us alive and get the oxygenation that we need. And that then now we take so much air volume in that it can actually kind of constrict our airway tube. So we kind of have a double whammy going on. We have too much air going in too fast, which makes the air tube collapse or close up temporarily. And then on top of that, we've got this big muscular structure called our tongue falling in because our jaw is low, falling into our throat and blocking our airway even more. And even though we're talking about adults right now, a lot of those things can also be present in children. So if we see children, toddlers, middle, like elementary, middle, and older, you see kids that are sleeping and their heads are kinked and they're like kind of all over the place and their mouth is open and they have really heavy breathing or they're snoring. Those are airway red flags. And we need the tongue to be able to support all of this, okay? All right, so one of the saddest things that ever happens is when parents come into my office with their child and they literally cry their eyes out. And I know exactly what they mean because I've been there too. They're crying their eyes out because they know that something is not right with their child. They're not sleeping well. They're very overstimulated. They can't regulate their emotions or the behaviors. They have huge bags underneath their eyes all the time. They look tired. They act tired. And these parents have literally talked to everyone. They've talked to their pediatrician. They've talked to their pediatric dentist or their regular dentist. They've gone to ENT. Sometimes they've had allergy tests. Sometimes they've had scopes put up the kid's nose to see if the adenoids are blocking the airway. And everyone tells them, no, no, no. They look at you and they devalue your opinion. And this is the saddest thing. And this isn't my opinion. This is what people tell me. They are just so discouraged because the professionals that they are going to seek answers, to seek help for their child, are basically looking at them and saying, you're full of it. You don't know what you're talking about. And that's not a real thing. That is the saddest thing that happens ever, regardless of what your concern is, who your doctor is. It doesn't matter what your issue is. When your professional people, your doctors, are looking at you straight in the face and saying, that's not real, you don't really have a problem, or your child doesn't really have a problem, hello, that is a problem. So we all have to work together. We all have to support our medical professionals, and we hope that the medical professionals will support us as well. But the unfortunate part is that many of them have not been trained on that posterior tongue tie or the fascial connection, that fascial piece. They haven't learned it, so they don't understand it. And because they don't understand it, the common experience that's shared is that patients are feeling belittled, they're feeling dismissed, invalidated, and they're told that their concerns are not real, they're not legitimate. And we hear this all the time when we see these families come in, and I look at them and I'm like, you are not crazy. And we start going through our evaluation and we start talking about the symptoms and the functions. And the moms sometimes hug off. Like they'll come and give us a big hug because they're like, thank you so much. You are the only person who has not talked to us like we're crazy. You're the only person who has validated that this is a real thing and that I wasn't just making stuff up. And I think that is probably without doubt the hardest part of this field, because everyone is dismissed, and it is so discouraging. Anyway, so we hear this all the time. We discuss that hidden tie, that posterior tie. We're able to connect the movement of the tongue with these functions, with these problems that either you yourself as the parent or your child are having. And our goal is to always explain things that make sense, show you pictures, kind of like what we're doing right now. We're going to talk about everything, all the issues that you have concerns about, and then bring the airway component into it, because in modern traditional medicine and dental environments, function is not a priority. Function is not taught. And we know from, hundreds of years of medical textbooks, dental textbooks, that the form follows function. So if things don't function well, muscles don't function well, the form or the structure is going to take a hit. So just like if you have weak muscles in your legs, those weak muscles are going to affect the way your bones grow. Or if we don't exercise or walk or put weight on our bones, that's going to affect the way we function, because the muscle is what guides the hard structures, guides the bone, the skeletal growth, the teeth positioning, how we swallow, can move the teeth. Form follows function. And you mamas who are watching this, you are not crazy. Always trust your mama gut, because when you know something is wrong, you're always like 100%, you're 100% right. You know it. You just know it. And that's the hard part in this profession. So, okay. We're going to talk a little bit about our functional assessment and how that differs from the doctor or dentist just looking at you and saying, no, you don't have tongue tie. All right. So we do look at what it looks like. We do, because there's more than just looking for that frenulum that we're looking for. We perform deep functional assessments to see how the tongue moves. So we have to see how it functions. We take these range of motion measurements that I talked about earlier with these paper rulers. I need to be able to see how the back of your tongue is able to elevate and how it moves. And then I'm also looking for compensations on the bottom of the mouth, on the floor of the mouth, and what's happening down there. And we'll often put gloves on, and we'll feel with fingers underneath your tongue, have you move your tongue. We're feeling for tight bands of tissue that we can't see. We may also touch and palpate a little bit, like right underneath your chin, The floor of the mouth is right here too. Do we feel tension? Do you feel pulling? Do you feel tension? Do you have, tension that and pulling that kind of runs down the front of your neck? Guess what? That's fascia. That's part of that posterior tie. Okay, so in my practice in particular, so my main office is in Oostburg, Wisconsin. And then I have a practice location up in De Pere, that's by Green Bay. And then I also see patients in Appleton. I go there once a month. So despite there being like an hour to an hour and a half between our locations, most people where I live, they come here and they say, I really don't want to have a tongue tie release unless it is absolutely necessary and there's no other option. I absolutely agree with that as well. So that makes me a little bit different than some other myofunctional therapy practices out there, because my approach is muscle first. When you have had a dysfunctional tongue movement, dysfunctional range of motion of your tongue, that leads to dysfunctional swallows, that leads to the clenching and grinding. Maybe we still have bedwetting in children at night. We're clenching, grinding our teeth. We're snoring, sleep apnea, whatever the concerns are. All of those muscles are responsible for all of those things, right? So all these muscles have to do lots of jobs. They have to eat, chew, swallow, talk, breathe. They have lots of jobs to do. And if they have had dysfunction or haven't worked to their full potential their whole life, you literally have an entire muscular system that has not been developed yet. So what do I mean by that? What I mean is unless you're one of those people who just has that very obvious anterior tongue tie that we talked a lot about in the beginning, I'm not going to always recommend a tongue tie release for most people, at least not right away. So my approach is that I like to develop your muscle system first. So what does that mean? That means we do myofunctional therapy, because when you come in for your evaluation, all I can base everything on is what I see right then during that evaluation. I don't really know yet what your muscles and what your function is capable of until we start rehabilitating those muscles and allowing them to do the jobs that they're anatomically designed to do. So once that muscle system is developed, if there's still restriction or we have that tie that's just holding us back from meeting our range of motion and our function goals, then if we can't meet those goals, then we talk about tongue tie release again after we've already started therapy. So typically, I'll tell my clients, like, okay, let's start with therapy. Let's do 3, 4, maybe 5 sessions. And that could be anywhere from 4 to 6 months or so worth of time. And if your symptoms are not improving and it doesn't appear that you can make the things happen the way we need them to, then I want to reassess to see what your tongue function is, and then where is that posterior tie coming into place. And if we're hitting that brick wall and we can't get any further with therapy, then I'll say, okay, let's go get assessed by a functional tongue tie release provider. And that is typically a very specifically trained airway dental provider. So I want to develop your muscle system first. And if you think about it, if you have a bad leg or you have a bad knee, okay, it's not usually, unless you had like a fall injury and you cracked your bones or something, say you have a bad knee, it's not usually the bones that are the problem. It's all the soft tissue and muscles around the knee that are causing the problem, right? So a surgeon is not going to just cut your leg open and do surgery on your leg without doing therapy first. And so I kind of tend to follow the same belief system and protocol. And the reason I do that is because I experienced that myself when I was doing myofunctional therapy. And I see that in my clients all the time. I feel like there's too much of an emphasis on, you come for a myofunctional therapy appointment, evaluation, and we can't do anything unless you have your tongue tie release. And that is a lot of what is taught. And that's some therapists will say, oh, you don't want to have your tongue tie release? Sorry, I'm not going to work with you. And I don't believe that, because we need to see what you can do first before we start cutting and changing your anatomy. So if we still have restrictions after function has been established, we'll talk about it. And I do have clients that have tongue tie releases, but 90% of them come in and say, I don't want to unless I absolutely need to. So the next several slides, these might be a little dry in the sense that I'm going to be talking about some of the things we look at. But these slides are actually from my myofunctional therapy evaluation. So if you come and have that done, you will see these slides again at some point. But we have to do the functional assessment, okay? Functional assessment. Yes, there is a part about looking at appearance because we have to know what these strings look like, right? We need to know what kind of shapes they're pulling the tongue in. But no one else is talking about symptoms. Are you clenching your teeth? Are you grinding? Do you have headaches? Do you have jaw pain? Do you have neck and shoulder problems? Is your child who's 12 years old still wetting the bed? Are they grinding their teeth at night? Are they snoring? Those are all the symptoms that have a direct connection to how this tongue is working. And what are the compensations? So I mentioned this word a couple times. I haven't really explained it quite yet, but a compensation is how other muscles have to move and have to respond in order to help your tongue do the job that it should do all by itself. So when I ask you to do certain movements with your tongue, I'm watching, what are your lips doing? What are your cheeks doing? Are you shifting your jaw side to side? Is your neck tensing and straining? Are you looking up? Are your shoulders tensing up? So I'm looking at your whole upper body structure to see what is overengaging that shouldn't be for your tongue to be able to do a relatively simple range of motion movement. I want to talk about these couple tongues here because this one is that anterior tie, right? We talked a lot about those. All of these people also have a posterior tongue tie. Okay. Now in this picture, we see like that string here, that frenum. We call it submucosal, which means it doesn't stick out, like it's not defined like this one. It's more embedded, it's more deep into the tongue muscles. And then we see it, this white line kind of from here to here, kind of stops here, but it doesn't stop there. If you look at this deep line that continues to go up to the tip of the tongue, that's where that frenulum extends deeper in. It continues to travel up the body of the tongue. The same thing happens here. This string is a lot skinnier. The physical outside part stops right there. But if you look really closely, you can see this whiteness, or we call it blanching, continues all the way to the tip of the tongue. And that tissue is embedding into these muscles here. And that's what's kind of pulling this tongue into this like flatter position. And same thing here. It ends right here. You can see that white blanching continues. And in this case, the tissue is being pulled into this notch. There's this little notch on the tip of the tongue. That's a direct pulling of that fascia on the tip of the tongue, pulling it into those shapes. Same thing here. Lots and lots of different shapes. I'm not going to go through every single one of these. All of these shapes are being impacted and pulled by the tension of the posterior fascia or the deep line fascia. I do look for something like, if you look at this, we see this kind of depression on the tongue, or this little dish that pulls down. If you think about how that attachment attaches underneath your tongue, that divot is the pressure pulling from the underside. And then we see that depression on the top part of the tongue. Again, these are different shapes, different presentations, different shapes these tongues can be pulled into. We've got this notch again here. We've got this whale tail or this heart. This is normal. This is normal. This person can open their mouth really far, and the floor of the mouth isn't lifting. We'll talk about that next. So I'm going to jump ahead to that slide. So the floor of the mouth lifting, if you look at these three people, they look how big they can open their mouth. They can open their mouth so big. And look how tall they can reach their tongue. So sometimes they'll look at this and be like, no, that's not a tongue. No way. You don't have a tongue tie. Look how big you're opening your mouth. Look how tall you're reaching your tongue. But floor of the mouth compensation is the biggest one that exists. And what do I mean by that? Look at this picture. So everything from here down is the floor of the mouth. All of this tissue should be down here behind the teeth in the floor of the mouth. The only reason that these people, same thing here, all of this should be down here. The only reason that these people can lift up that tall is because they're pulling their whole floor of the mouth up with them. And during an evaluation, I will actually, when I have my glove on, I will gently put my finger down there and hold down the floor of the mouth and ask you to lift up. And guess what? When that happens, when this part of your mouth is staying down here where it's supposed to be, you can't lift your tongue up this tall anymore. And that's a direct connection to how that fascia is embedded into the tongue and then embeds into the floor of the mouth. Okay. So I'm going to jump back those couple slides now. And I want to talk about this presentation as well, because this is called an Eiffel Tower attachment. If you look at it and you look at the way it fans out like this, it looks like an Eiffel Tower. Same thing here, it kind of fans out. Looks like an Eiffel Tower. What's happening with this is an extension. So it's easier to see on this picture here, but you can see these bumps right here. Those are salivary glands that are underneath your tongue, and they're supposed to be there. And ideally, this frenulum should insert or stop right about there. It should stop right about there. But in these cases, that tissue, it flares out and it extends to the jawbone right behind the lower teeth. And this can be a pretty significant visual of we have a little bit more restriction to the back part of our tongue than we do if we don't have this, because now instead of this connection ending and connecting into soft squishy tissue that's underneath our tongue, now it's connecting to hard bony structure. Okay. And that's going to limit the back of the tongue from being able to lift up. And we can kind of see that here. This is a hard picture to see, but you see all this black back here? That's all the throat. And the reason it's black is just because we don't have any light shining back there. But here's the tongue. So the back of the tongue is right here. And then it kind of goes and it goes over here. The back of that tongue is not able to lift up and make contact with the roof of the mouth. And when that can't happen, that's when we suspect some of that restriction, and that has a direct connection to some of that posterior or some of those compensations that we have, okay? Same thing here. This person's floor of mouth is lifting up really tall. All of this should be down here. The string kind of connects, or, well, I should say, with my trained eye, I can tell that this tissue is kind of flaring out. It's not as obvious as these pictures, but once we start to get tone in the tongue and tone in the floor of the mouth, we will see that tissue pop out and it will look more like this. Okay. These are more examples of compensation. Can you move your tongue from side to side without dragging on your lips, without moving your chin all over the place? Is your tongue kind of flopping on the side? Like in this position, we can see this person has this big dent on the tip of their tongue. Same thing here, we can kind of see that restriction. So we're looking at all of these things when we're doing your evaluations. That's that floor of the mouth compensation. We just talked about that. Another thing we're looking for too is how easily can you do what we call a lingual palatal suction, or you're sticking your tongue up to the roof of your mouth and holding it. And can you maintain it in that position and still be able to open your mouth? This picture on the right, this is me. Over 2 years ago, just over 2 years ago, I had a posterior tongue tie release. And you can see that I still have a string. I still have a frenulum. So posterior tongue tie release is not going to take away your string because it's not focused on this part. This part isn't the restriction. It's all that stuff behind it. So I wish I could zoom this in so you could see this better. But back here, there's like this kind of black spot. There's this black spot here. We call those caves or tunnels. And when the back of your tongue can really lift up and suction, you get almost these tunnels down the side of your mouth. And that's an indication that you're able to engage your whole tongue body with the roof of the mouth. This person, you can see the tongue, it kind of flaps over, it spills outside of the tongue. They also have these like scallop lines. You see these little bumps and scallops on the sides of their tongue. Those scallops are there because their tongue is not fitting into their space here. So then we start to see the indentations of the tongue or on the of the teeth on the tongue. But she can't open her mouth very far right now. And we can't see any of that cave or tunnel in her tongue because it's all just spilling out and it's not able to stay up in that space. So this is a validated protocol by Dr. Zaghi of the Breathe Institute. He is one of the, if not, well, he is one of the main educators for dentist offices who are doing what we call a functional frenuloplasty, aka posterior tongue tie release. This is the classification system that he came up with, and we have 4 different grades. There's grade 1, 2, 3, and 4. 4 is the most restrictive or most severe. 1 is within normal limits or even slightly above average. So I am going to put someone into a category based on this, but I also don't love this protocol either, because again, you might look like this, say you're a class 3 when you come in to see me, but I don't know really what your true tongue restriction is until we develop your muscles, and then I can see what you can do, and then how do your symptoms improve. So we'll reclassify this again as we go through therapy. I put this in a second time, this fascia, because we talked about this a lot, and this is a foreign concept to a lot of people. But the frontline fascia, it's all connected. It's a continuous deep line of connective tissue linking the tongue to the jaw, neck, diaphragm, and pelvic floor. A posterior tongue tie acts as a rigid, hidden restriction within this chain, causing compensatory habits like low resting tongue posture, mouth breathing, and chronic jaw or neck tension. So what are the impacts of the posterior tie on oral function? We have restricted mobility, breathing issues, feeding difficulties in infants, skeletal and muscular compensations, and this can affect dental health and increase the risk of cavities as well, because we're mouth breathing, and that changes the bacterial composition in the mouth. It's just this whole cascading situation. Okay, so when we get to the point where there's a suspected release and it is impacting your function, then we need to make referrals and we need to connect with other professionals who can help you with that next step, okay? So first step is, again, we have to develop your muscle system through myofunctional therapy. Then we reassess. So we're reevaluating your range of motion and how have you developed through your therapy journey. And then if we get to that point where we need to refer, I'm going to refer you to a specific airway trained dental provider. My office is in Oostburg, my main office, which is right outside of Sheboygan. I'm fortunate that in the area I live in, there's amazing airway trained dentists north and south of me. So I have several options of people that I can send you to if you're in the state of Wisconsin. And if you're outside of the state of Wisconsin and we're working together virtually, I also have a large network of people out of state that I can connect you with as well. And then that fourth step, if needed, would be releasing. So having that functional tongue tie release to address that deep connection, that deep fascial tissue. I do want to say there should probably be a step 5 here, because after the release, we have to continue with post-op myofunctional therapy stretches to ensure that you maintain your range of motion, you don't heal too quickly and form scar tissue that's going to start to restrict your function before, like to where it was before we started. Traditionally trained ENTs, dentists, and other medical professionals are only addressing the front part of that tongue. We talked a lot about that. The functional release addresses the whole mobility of the tongue. It allows the tongue to restore its ability to have full mobility. And that's the difference, okay? So I always caution, if there's anything that you get from this webinar tonight, anything at all, the one thing that I just want you to be aware of is that if you suspect you have a tongue tie, whether it's anterior or posterior, let's say it's posterior because that's the one most doctors don't know about. You show them underneath your tongue and they see that frenulum and they're just looking at the string. And sometimes they say, oh, I see a string. Sure. Yep. You have a tongue tie. Guess what? I have a string too. Okay. So it's not about that string. Sometimes like a dentist will say, oh, yeah, I can just snip that for you while you're here. I'll pull out my laser or I'll pull out my scissors or whatever tool it is that they use. FYI, laser is preferred, but it's not about the tool. It's about the hands that are using the tool. So keep that in mind as well. But laser is preferred because it's often no touch. There's almost zero bleeding risk, almost zero. And it's very safe and effective. But sometimes, oh yeah, you think you have a tongue tie? Sure, I'll snip that for you while you're here. Unless you have that anterior tie, them just snipping your string is not going to improve your posterior tongue function. All it's going to do is allow the front part of the tongue to move more. But if your front part of the tongue already moves and it's not connected to the floor of your mouth, that clip or snip is not going to help you. We have to get you to the right professional that is trained in that fascial part that's right behind that string. Otherwise, you just wasted a lot of time and money, okay? So if you have questions about that too, please reach out to us and we will help connect you with airway-focused functional frenuloplasty providers who are going to do a functional tongue tie release and not just release that string for you. Also, I would caution if they ever do offer to do that and they didn't ask you to do any myofunctional therapy before or after, that's just another red flag that, hey, maybe this doctor isn't really fully trained in function and maybe I should look at other options, again, the second opinion before I just let them do that on the spot. They're not doing anything wrong, okay? They can. It's just that they're not understanding the posterior part of it, the way the back part of the tongue is going to move, and that releasing that string is not going to improve your range of motion. It is not going to improve the posterior back part of your tongue. So as we finish up, oftentimes there's this misconception that if I have my tongue tie release, it's going to fix all my problems. The success is not based on whether or not you have the release. You really want to focus on doing the whole thing. Think about having, again, knee surgery or hip or shoulder surgery without having physical therapy. If you don't address the muscle function, the symptoms are going to come back or they're not even going to resolve in the first place, okay? And one of the things that I tell my clients, and it's the same thing I was talking about earlier, when you address the muscle function and you work on the muscular system, okay? We're working on muscles. So there is going to be some improvement to your symptoms. There has to be. You can't do muscle therapy and not have improvements. But we have to make sure that if that physical string is impacting your ability to improve, then we want to have that conversation again. And really, the functional frenuloplasty, it's a very quick procedure. It does not take very much time. It is important that we do all the pre and post procedure stretches, but it's not surgery in the sense that you're going to the ER and they're putting you to sleep. You're awake. You have a little tiny bit of numbing. It's very quick, and it's really life-changing. And I know that for myself and for all the patients that I've worked with that have had theirs done. It is life-changing if you do it the right way and you prepare for it the right way. All right, so I know I threw a lot of information at everybody tonight. I appreciate you sticking with me. I hope that if anything, if you're in the airway realm or you're following myofunctional therapy pages and you're starting to see some of this stuff on Facebook or Instagram or TikTok, and I hope that if anything, tonight's webinar will encourage you to start doing some research. Look this stuff up, ask questions. You always want to vet whoever you're working with, whether it's a dentist, a doctor, a myofunctional therapist, a massage therapist. It doesn't matter who you're seeing. ask the questions because you're investing your time and money into the service and product that they're providing for you. I want you to get as much out of that as possible. And the best way to do that is to research for yourself, advocate for yourself, and then reach out and ask questions. So we will always take time to answer your questions. We do offer a free consultation call. You can send us an email as well, and we can connect with you that way. So if you do ever have any questions, find our website, wisconsinmyo.com, and send us a message. And with that said, okay, I just have like my image sources and things right there. But with that said, I'm going to stop the recording here because sometimes the questions that are asked are personal and they're sensitive. So I don't want to have those recorded, and those won't be shared with everyone who registered. But if you did register for this and you want to rewatch it again, you will get this video link in your email tomorrow afternoon, and it will also get shared with everyone else who registered for tonight. So thank you so much, everybody, for joining us tonight. Reach out with any questions, and we look forward to connecting with you.